So thank you everybody for joining. Nico Piazza is back with us, which is a real treat. Nico, I got so many messages, emails, and phone calls after your talk last week, where people have told me they've watched it 2 or 3 times already, and every time they're learning more. And even experienced interventionists have reached out to me saying how it's changed the way they look at a coronary angiogram. So thank you so much, and we're looking forward to today.
All right, thanks, Azim. Today, we're going to shift gear towards more structural heart interventions. Last week, we spoke about coronaries. Today, we'll talk about transeptal puncture and how to better understand transeptal punctures with respect to chamber views and S-curves. And also, we're going to go into the mitral valve. So we're not going to be touching the tricuspid valve today. That can be a topic for another time. Before I start with the slides, I just wanted to share this with you. These are the key references that really summarize last week's and this week's series of lectures. And we also have a monstrous chapter in the PCRE PCI textbook on the fluoroscopic anatomy for guidance of percutaneous transcatheter interventions, and that's both for coronary and structural. So one thing that we don't think about necessarily when we're in the cath lab is the attitudinal description of the heart. And this describes position of the heart and its structures with respect to what's anterior, posterior, superior, right, and left. And this is the same nomenclature that is being used in CT and MRI. Unfortunately, it's not what's being used in echocardiography. And so that sometimes creates a little bit of confusion when we try to understand the relative position of things in the heart. For example, the posterior leaflet of the tricuspid valve is literally an inferior leaflet. It is inferior to the septal and anterior leaflet. The anterior leaflet of the tricuspid valve is in fact anteral superior. And the septal leaflet of the tricuspid valve is really a posterior leaflet. And so once you start to understand where things are actually located in the heart with respect to the attitudinal description, you can easily maneuver your catheters towards your target structure. We're going to rehash some of last week's slides, maybe a couple, just to solidify and remind some people that chamber views, in this case, the 3-chamber view of the heart, can be seen across different imaging modalities. What you see on echo is what you get on fluoro, is what you get on CT, is what you get on MRI. Some are static, some are dynamic. The chamber view concepts is well ingrained in the echocardiography field. And so we have the 1-chamber or short axis view of the heart. We have the bicommissural or 2-chamber view of the heart. We have the LVOT or 3-chamber view. And we have the 4-chamber view of the left heart. And remember, these chamber views can be obtained on CT. The 3-chamber view in ariocaudal, the short axis or the 1-chamber view in elaiocaudal, the 4-chamber view in elaeocranial, and if we go to the ario 30, cranial tenabelt, shallow areocranial, which is our typical LV gram we perform in the cath lab every day, we get the 2-chamber view with overlap of the aortic and mitral valve. And so this is the fluoroscopic formula for chamber views on the left side of the heart. You have the 1, 3, 2, and 4 in elaiocaudal, areocranial, and elaeocranial respectively. And those are the corresponding echocardiographic images that we might see as well. And so we are trying to move towards pattern recognition in structural heart disease, as we've done for the past 40 some years for coronary interventions. And so, for example, in the two-chamber view, you'll always have an overlap of your mitral and aortic valve, as you see there in yellow and turquoise. In the two-chamber view, you'll always have the major axis of your mitral and aortic valve as well. You can get the atrial septum in plane if you like to. You see there it's slightly off axis. And you do get the minor axis of the left atrial appendage. On the three-chamber view, for example, you separate the aortic and mitral valve. You get the minor axis of the mitral valve. You get the minor axis of the aortic valve. And typically, it's the view where you have the atrial septum en face. And so because it's en face, because the aortic valve has been separated from the left atrium, the three-chamber view, ariocaudal, is the best view to allow you to understand whether or not your transeptal needle, which should be pointing into the screen in ariocaudal, is away from your aortic root. That's how you separate what's anterior and what's posterior. Anterior mitral valve leaflet, posterior mitral valve leaflet. Right? When you do a transeptal puncture, you want to go posterior, get away from the aortic valve. And so you can do this for countless numbers of relationships between structures and comparing the different chamber views. Now, that was the left side of the heart. We also have chamber views on the right side. And for those of you who are familiar with echocardiography, you know that when an echocardiographer has a three-chamber view of the left heart, and they translate that more anterior into the right side, they go from a three-chamber left to a two-chamber right. On the other hand, when you got a two-chamber of the left heart and you slide anterior into the right heart, you'll end up in a three-chamber or RVOT outflow view. And so what we'll see is the exact same thing on fluoroscopy. Where you had the three-chamber view of the left heart, now you get the two-chamber view of the right heart. Where you have the two-chamber view of the left heart, now you'll get the three-chamber view of the right heart. The one-chamber and four-chamber, of course, are going to stay the same. So let's look at the right heart. Ariocaudal two-chamber. I'll just restart that so that you can ingrain that picture. Notice that the shape of the two-chamber view is the exact same thing as we see in the left heart. You have the ventricle, you have the appendage, right atrial appendage, and you got the right atrium. Okay? And so the orientation of the appendage and the RV in a two-chamber left and a two-chamber right is almost very similar. I just want to pinpoint a particular structure because it's going to become important in the next 2 or 3 slides. It's this right here. This here is the coronary sinus. Okay? And the coronary sinus in a two-chamber view of the right heart is usually perpendicular to the tricuspid valve annulus. Okay? Notice that the coronary sinus in a two-chamber view points directly downwards. Okay? This is anterior. You have the sternum. So what's anterior, the opposite needs to be posterior. Okay? And so the coronary sinus is a posterior structure. Okay, but let's clean this up and we will make the video run. Sorry, I'm just using this eraser, which is not very efficient. Okay, let me go back to my arrow. Okay, so two-chamber view of the right heart in ariocaudal. We're going to a short axis view, or what I like to call a one-chamber view of the right heart in aleocaudal. Notice it's really a double barrel of the left and right heart. You have the short axis of the right heart here, and you have the short axis of the left heart here. Okay, so we're in aleocaudal. We're going to go to a four-chamber view in aleocranial. That's easy to understand. And now, instead of the everyday LV-gram in a two-chamber view of the left heart, notice that we get a three-chamber view, or RVOT view, right ventricular offload tract view of the right heart. So this is the fluoroscopic formula for the right heart. You got the one chamber in aleocaudal, the two chamber in ariocaudal, the three chamber in ariocranial, and the four chamber in aleocranial. Now, there's going to be two examples, and last week Azim mentioned something about pacemakers and me showing an example in the past. And so I pulled up that example again. But during the course of the week, I actually ran into a different problem, but yet similar. So, and I'll share with you as well. So this is a two-chamber view of the tricuspid valve. Okay. You notice on the left-hand side, we had a CT scan of this patient. You can notice that the surgical bioprosthetic valve on the tricuspid position is oriented in the same manner in the CT as it is on the fluoroscopy. Okay. And we were trying to float, or at least get access into the right ventricle and pulmonary artery, because we were going to perform a valve-in-valve within this failed tricuspid surgical prosthesis. The problem was that we kept on going into this area and space that, at least initially, was a little bit boggling, and we didn't understand why. So you got the bioprosthetic tricuspid valve, you got your end-hole wedge catheter, and there, again, is that coronary sinus that is perpendicular, almost, at 90 degrees with the tricuspid valve in ariocaudal. And so when you marriage the fluoroscopy and your pre-procedural CT to understand where things are, okay, and you can actually see that things align exactly the same. Okay, look at this pacemaker lead here with that artifact behind the CT scan. Notice these two things here are reflections of this. Okay, so and here's your bioprosthesis overlapped with your let me just erase this here. Okay, so the problem was that we were entering the coronary sinus repeatedly. And so the way to deal with that is you got to do two things. You need to bring your catheter more superior, okay, and you gotta give it more anterior torque. Now, this was the other problem we had earlier today during a TAVI. We had the pacemaker positioned, and somehow we were getting atrial beats. We were pacing the atrium. We weren't pacing the ventricle, or at least it looked to be a sort of fusion of something. And so I told our fellow, I said, look, don't do anything. Leave the pacemaker where it is. Let's go in ariocaudal, okay, and understand what's happening with this pacemaker in a different view. And so I said, look, if this pacemaker is in the coronary sinus, it's going to be pointing south in ariocaudal. And lo and behold, what happened? This pacemaker was pointing south. Okay. Now notice that you also have stents in the RCA. Okay. We're not truly coplanar with the tricuspid valve, but we could have gone into some view that brings these stents somewhat more in this fashion, you know, straight on. Now, in order to deal with this again, you need to pull up your pacemaker and get high and ride high across the tricuspid annulus. And so when you do this properly, this is what you get instead. Okay, you can see that you've elongated the distance from your right atrium to the tip of your right ventricle. Okay, so we're not going to be talking about the right side of the heart any longer. We're going back to the left side and S-curves. But let's talk about the S-curve. The S-curve allows you to understand the RAO and LAOs with corresponding cranial and caudal projections where your structure is in plane. So all those points on the curve give you an idea of where your structure is in plane. This is an example of the mitral valve. You can see that as you're driving along the S-curve, your mitral valve always stays in plane. Also remember from last week that as you drive along the S-curve, you're driving across the fluoroscopic grid. As you're driving across the fluoroscopic grid, you're going to come across different chamber views. And so now you can start to combine chamber views and S-curves and try to get the best chamber view with your structure in plane or en face in order to perform your procedures. Remember that we can get S-curves really for any structure in the heart, whether it's the aortic annulus, the mitral valve, the left atrial appendage, the atrial septum, the coronary ostia, the ascending aorta, the LVOT, the SVC, IVC, coronary sinus, and so on. And each of these structures has an average S-curve. And it's quite amazing that despite the rotations of the heart, despite the dilatations of the heart, that these S-curves are, for the most part, very, very, very stable in what they do. Of course, you have outliers every once in a while, but these outliers still have S-curves of their structures that are really the same as those with normal hearts. And so what you see here are average S-curves of roughly 100 patients of the aortic annulus, mitral annulus, left atrial appendage, and atrial septum. And take note that these are patients with either mitral regurg in blue or aortic stenosis in red. And we could have easily added patients with normal hearts in green, for instance. And all of these curves would have very, very similar orientations. Now, we're going to be talking about the mitral annulus. That's the second figure that you see there. So you can see that the S-curves of the mitral annulus intersects the areocranial, iliocranial, and ariocaudal quadrants. There's always one quadrant that the S-curve does not intersect. That's the quadrant where that structure is seen en face, okay? And so if you remember the general shape of these S-curves, which I have, and so do my fellows, then you will understand in which projections you might get your structures seen in plane or en face. The other structure that we're going to be talking about today is the atrial septum. That's on the far right-hand side. Note that the atrial septum S-curve intersects the areocranial, iliocranial, and iliocaudal quadrants, and that the atrial septum is seen en face in a three-chamber view of the left heart. Remember, we explained that in the three-chamber view of the left heart, you separate the aortic from the mitral valve, and we had the atrial septum en face. So the atrial septum is seen en face in the three-chamber view of the left heart. And we're also going to see a cartoon drawing, and you may see this in a bunch of cartoon drawings when they explain the anatomy of the atrial septum from the right heart. If you ever see an en face drawing of the atrial septum of the right heart, okay, you're talking about a two-chamber view of the right heart. Okay, that's an areocaudal. Also remember that if two structures have very similar orientations, in this case, you have the atrial septum in green and the left atrial appendage in orange, that their S-curves are going to be very, very similar. Okay, and so you can see that both of these S-curves avoid the areocaudal quadrant. That's because the areocaudal quadrant has the left atrial appendage and the atrial septum en face, which again brings me to another point. If you understand this, you tell yourself never, ever, ever implant a left atrial appendage device in a steep areocaudal view, because you're going to start getting towards the atrial appendage en face. So let's talk about transeptal punctures. Now, all of this concept about chamber views and S-curves and understanding fluoroscopic anatomy comes from the CT scan. And I use CT scans all the time to understand whatever procedure I'm going to be doing, whether it's coronary or structural, whether it's an old procedure, whether it's a new procedure. Always ask yourself, can we enhance the actual technique? Can we enhance our understanding of what we're doing? Now, this is I would say, a transverse cut across the heart, which means that it's a cranial 90. We cannot get that on fluoroscopy, of course. But this would be a cranial 90 view, a transverse view of the heart. Notice that you have the right atrium. You have the right atrium here. You have the left atrium here. And of course, you have the atrial septum there. Now, what I've done is I've oriented what's anterior, posterior, right and left based on the attitudinal description of the heart, more or less. Now notice that if we're going to be puncturing from the right to the left side of the heart, okay, we can think about this, of course, in a clock, using a clock as a background. We're always taught that we need to puncture the atrial septum at 5 o'clock or 6 o'clock, or if the atrial septum is more posterior, at 7 or 8 o'clock. And so this allows you to understand why we say 5 o'clock. Notice that the arrow here, okay, is pointing somewhere to about 5, 6 o'clock. Okay. Now, once you get into the left atrium, we always tell people you gotta counterclock, okay, towards 3 o'clock. Why do we counterclock? Because we get off the posterior wall, because we might want to get towards the mitral valve. Okay, so counterclocking from a posterior location gets you closer to the mitral valve and towards the anterior aspect of the heart. Okay, notice on the right-hand side, I have a fluoroscopic image of a quasi three-chamber view, an REO 30, caudal 15. In this particular patient, that's where the atrial septum was seen en face. So we're going to be taking a deep dive into transeptal punctures. So this is the atrial septum S-curve. And again, the atrial septum is seen en face in a REO caudal view. Now we can draw S-curves for different patients with different types of atrial septum S-curves. And this is something that happens every so often, not uncommon. Again, you see these curves are all intersecting the same quadrants, and they leave the areocaudal quadrant free. If you have a vertical S-curve, you will have a vertical structure in the heart, literally. So this would be vertical in my body. If you have a horizontal S-curve, you will have literally a horizontal structure in the heart. And so if I have a horizontal structure in the heart, my C-arm has to go from LAO 90 to REO 90 to always see this in plane. If you take those points and you plot them on the fluoroscopic grid, you're going to get a horizontal line at some cranial or some caudal view. And so the middle S-curve you see is pretty vertical. And so this patient had a vertical atrial septum. Okay. On the right-hand side, the patient had right atrial enlargement, severe right atrial enlargement, and the S-curve became more horizontal. Just a little, why is this important is because when I see these different variations, I start to tell myself, what type of needle curve do I need? And am I going to puncture this from below, from IVC going upwards, or am I going to do the traditional SVC and come downwards? And so maybe I'll do a little drawing here on the side. So if you have your SVC, you have your atrial septum, and you have your IVC here, and you get your right atrium with your right atrial appendage. If we have a rather vertical atrial septum, and by the way, this is a bicable view of the heart, right? Because you get your SVC and IVC. Okay, for these type of patients, I'm going to come from above, and I'm going to make sure that I have a nice curve on my needle. Otherwise, you're just going to slip off. Okay. On the other hand, if you're dealing with a septum that does something like this, we get the SVC. I'm going to exaggerate this. You get the IVC, right atrial appendage. And now you have your atrial septum here. That's horizontal. You can see that if you come from above with your needle pointing and you try to come down, this is going to be very difficult. Okay, so if I ever have horizontal septums, I like to come from below. And if I do come from below, I don't put a big curve. I put a very shallow curve so that I can point more upwards. So these are the two views that we use for echocardiographic transeptal puncture. We have the bicable view on the left. We have the short axis view on the right. And we always ask ourselves, well, okay, we need to go superior, we need to go posterior for a particular procedure. And what we'll see is that in order to best understand your transeptal puncture, you need to understand, first of all, what is your target structure? Is it the lateral commissure of the mitral valve? Is it the left atrial appendage? Are you trying to hover in the middle of the mitral valve? Are you trying to get height on the mitral valve, or are you trying to be shallow from the mitral valve? And so all of these questions become very important. And as soon as you understand where your atrial septum is relative to your target structure in the bicable and short axis view, then you'll understand why you would need to do a certain type of location of puncture for your procedure. And if ever a new procedure comes out, it also gives you a basis for you to be creative and maybe provide some suggestions. So let's look at the atrial septum en face. This is the atrial septum seen from the right side of the heart. Okay. And again, if the atrial septum is en face in ariocaudal and we're in the right side of the heart, we're going to get a two-chamber view of the heart. That's what we see here. Notice the drawing you have on the right-hand side. Okay. If you're seeing an atrial septum en face, that drawing is a two-chamber view of the right heart. And you see that it gives you different locations, or at least it's trying to explain to you where you would perform a transeptal puncture for different procedures. So for example, the red dot, okay, is posterior. It's away from the aortic valve, and it has height from the mitral, as we'll see. Whereas the green is posterior, but it is shallower to the mitral valve. And so the red dot would be something you might do for a mitral clip. The green dot might be something you do for a left atrial appendage or cardioband. The blue dot is something maybe you might want to do for a transeptal mitral valve replacement with a large bore catheter because you don't want to injure the rims of the heart. And so when you talk about a bicable view, then what you're doing is you're transecting the SVC all the way down to the IVC. When you're transecting on the short axis, of course, you need to get a short axis view of your aortic valve. Notice that this blue line is transecting the aortic valve. And so these are the planes through which you are working when you're going what's called superior or inferior, right? This would be superior, S. This would be inferior along the green line, right, in the bicable view. And what you would call anterior and posterior along this axis. Okay, and so you can see that the posterior, in fact, is going slightly inferior to what is anterior. And so this is why sometimes things get complicated, that when you go posterior, you might actually even be sliding more inferior. Now, I didn't tell you the whole story about the fluoroscopic anatomy of the heart. I left out two views that we don't use because, well, we do use one of them. But one of them, the other one is an extreme areocranial. So if you do want to get the en face view of the aortic valve, right, that's what you have on the short axis view. If you ever want to see your aortic valves en face, go in an extreme areocranial view. Okay, in the extreme areocranial view, okay, you see that we have the atrial septum in plane as we have it on the echo, but that's also where your aortic valve is en face. And we know that the aortic annulus S-curve typically intersects the iliocranial, slightly iliocaudal, and ariocaudal view, usually spares the ariocranial, and that's where you have the aortic valve en face. At the bottom left, you have the corresponding CT image of what we get on echo. Okay, so now we've put all together what we see on echo, what we see on CT, and where we would see it on fluoro. On the other hand, the bicable view, okay, is really something extremely LAO and usually some caudal. Okay, it's almost a lateral view. Okay, and remember, in the extreme LAOs and some caudal, that's where you get the mitral valve en face. You'll see that this becomes somewhat important because we're always doing mitral valves. We're always doing transeptal punctures with respect to a mitral valve procedure. But let's look at the echocardiographic image on the top right, and you see you have the corresponding CT image on the bottom right. Notice that you have in this area the right atrial appendage, which is anterior, right? We know the appendages are anterior structures, so that's anterior. And we have here the spine, and the spine must be posterior. We don't see the spine on echo. Okay, of course it makes sense. The left atrium, which is here, is posterior to the right atrium, which is here. Okay, and so this is the right atrial appendage here, and this is the SVC. Now, just a little anecdote, okay? When you're, and it's something annoying sometimes, when you're advancing that wire from the IVC into the SVC to start your transeptal puncture, it seems always to buckle into the right atrium somewhere, and you're sort of going up and down, and hopefully by chance one time it's going to go into the SVC. What's happening, okay, is the following. Okay, so I'm going to take this picture here, and I'm going to orient it as we see it on fluoroscopy. So we would get the SVC, we would get the right atrial appendage, the right atrium, we'd get the IVC, we'll get the atrial septum, and so what is happening in those cases, so this is that your wire comes up, it gets deflected by the atrial septum, and it goes straight up into the right atrial appendage. That's where your wire is buckling. So what you need to do is you need to pull back, okay, and you need to go more posterior, okay, because your SVC is more posterior, yet it's a relatively anterior structure, but it's more posterior than your right atrial appendage. Okay, and so all of these little nuances, okay, is just so you feel very confident with every move you're making in the cath lab. Okay, and you're not just pushing wires because eventually it's going to go somewhere. I know it probably doesn't have any implications to be pushing a wire 100 times perhaps in the right atrium, but still it could be annoying, and sometimes it's nice just to be very direct and very quick when you do things. Okay, so we understand the relationship between echo, CT, where we potentially see these things on fluoroscopy. Okay, and there it was. I didn't know it was going to come up, but let me erase this here. Okay, what you have in your drawings here is what we would see on fluoroscopy, the same orientation. Okay, so that's what I just finished drawing in the orange box in the iliocaudal quadrant. Okay, now, when we look at the bicable view, this is the bicable view on echo, but we have it now oriented based on what we see on fluoro. Okay. What you'll notice is that in the bicable view, and it's something you don't appreciate on echo, is that in behind the scenes, the mitral valve is almost en face. Okay, notice this, the mitral valve here is en face. The turquoise circle, that's the mitral valve. The atrial septum is pink. You have the lateral commissure right here, and you have the medial commissure here. Notice that the lateral commissure is actually superior compared to the medial commissure. So sometimes when I'm speaking to my colleagues, I'll talk in terms of superior commissure versus inferior commissure. Now, what you have closer to the medial commissures is your A3P3, followed by A2P2, and close to your lateral commissure, you have your A1, P1. Okay. So when you do your bicable puncture, as you're moving superior to inferior, what you're doing is you are hovering across the medial to lateral commissures. Very important. Below these commissures, right below, you have the papillary muscles. The papillary muscles are towers that sit below the lateral and medial commissures. Now, depending on what you want to do, okay, this might be important because, let me give you an example. If you want to target the lateral commissure, for instance, okay, what you want to do is do an inferior puncture so that you can get coaxial to your lateral commissure. You don't want to get superior because you're going to get a bad angle of attack. Now, what is right next to the lateral commissure? The next to the lateral commissure is the left atrial appendage, which is right here. This is why we tend to like to do inferior punctures to get into the left atrial appendage, because you become more coaxial. Okay, you don't want to go superior. Now, on the other hand, sometimes we talk about doing mitral clip procedures or some other mitral valve procedures. Okay, and we typically say go mid to superior so that you have somehow centralized yourself closer and that you'll be able to hover from commissure to commissure. Now, I'm going to share with you something later on to show you that, in fact, the relationship between the atrial septum, and this is some work we're doing right now, and the mitral valve, seen en face, or the atrial septum versus left atrial appendage, or any other target structure, is not always consistent from patient to patient. And so in some patients, it really doesn't matter where you puncture. You're going to be coaxial with the left atrial appendage, for instance. There are some other patients where you better be damn accurate and be inferior, otherwise you're going to be in trouble. The same thing is true for mitral clips. Same thing is true for some other types of procedures. Some anatomies lend themselves to being less accurate than others. Okay, so what I've highlighted here is an IVC puncture versus an SVC puncture, inferior superior. Now, this is what I was talking about. This is 3 times, it's 15 different patients, just to give you a sample, with their atrial septum and mitral valves. This is the type of work we're doing right now, trying to understand how things relate to each other. Okay, let me just pull up, let's see, 2 extreme cases. Here, let's take this one here. Okay, versus versus something like this here. Okay. Notice that this one here, okay, whether you puncture inferior or superior, I'm not sure it's going to make a whole lot of difference in getting across from the commissures with the red and blue dots. Okay, why? Because your atrial septum has come more inferior. On the other hand, you can see in this case where it may be more important whether you puncture superior or inferior. Okay, notice where the commissures are here. They're completely disjointed compared to where the commissures are relative to this atrial septum. Okay, notice that here you have a perfect line from commissure to commissure, whereas here the commissure is actually found behind. And so that also brings up the point of when you do cardiobands or other procedures, that where you puncture and where you have to wrap around and come back on yourselves might be different from patient to patient. Now let's talk about the short axis view. Now the short axis view has typically the aortic valve en face, but remember that in the short axis view, which is found on the fluoroscopic grid, right, in areocranial, right here we said, okay, has actually also the mitral valve in plane almost. Why? Because the S curve of the mitral valve does something like this. And so the S curve, we're going to get the mitral valve in plane in a high riding areocranial. This view here is areocranial. Note it's areo 68, cranial 44. And so the more posterior you go, the greater height you get from your mitral valve, which is in plane, and the more anterior you are, the less height you get against the mitral valve. Again, it's understanding the orientation of your target structure in the bicable and short axis views. Now, notice that this is where the left atrial appendage is, right here. Okay, and so in this case, what you want to do is you want to make sure you puncture posterior so you can get coaxial towards the anterior left atrial appendage. If you puncture too anterior, your angle of attack might be more compromised. So just want to play you this video. Now, notice that it starts in a bicable view. Notice that there are two dots right here. There's a yellow and red dot. Both of these dots are superior. Okay, they're both a superior puncture. Now look what happens as we go from a bicable view and we're going to a short axis view, more or less. Notice that now we have a separation of our dots. Notice that the yellow dot is inferior and the red dot is superior, giving you greater height from the mitral valve. So although they were both superior punctures to start with, it did not give you the same height from the mitral valve. Okay, this is another example where now you have a red dot here, a superior puncture, and a green dot here, which is inferior. Now look what happens if we play these videos relative to the mitral valve. One is superior, one is inferior. Okay, but now they are both superior, very high punctures relative to the mitral valve. Okay, so we did the flip side of the story. This is just a more in-depth explanation for left atrial appendage procedures. Notice that you have the blue turquoise dot, that's inferior. You have the red dot, which is superior in the bicable view. Okay, and so if you want to be more coaxial, like we said, we start from the blue dot to get into the left atrial appendage. And you can see also the relationship between the atrial septum and left atrial appendage. So again, now, when you look at these cartoons, when people start to explain to you transeptal punctures, you can start to tell yourself why you prefer a certain transeptal puncture for a given procedure. Okay. So for MitraClip, an SVC puncture or a mid puncture is to enable your catheter to be manipulated over the mitral valve, to be able to hover across the mitral valve from lateral to medial commissure. On the other hand, the posterior puncture is to get height above the mitral valve. So Azim, I think what I'll do is I'm going to stop here, and what we're going to, you know, I'll throw the invite to myself. Maybe in the future we can do part 3 and part 4. Part 3, I think I do the mitral valve coming from the transeptal puncture, and part 4 would be tricuspid. But I'll leave it up to you to decide in the, you know, later in the year or next year, whenever you guys are free.
That would be great, Nico. Thank you so much. It's, you know, once again, it just shows how often simplistic our thinking is about this, right? And about transeptal puncture, because I think, you know, one of the take-home messages I take as well is, I do transeptals all the time, is how there's so much variability. And, you know, with CT scans and having a CAT scan before, you can really tailor the puncture for that patient's anatomy. And we all forget that when we, you know, we do all the techniques of transeptal puncture are very much based on normal size atria, right? And then once suddenly one atrium is bigger than the other, it changes all that anatomy. And what you would normally do to get a good MitraClip puncture in another patient, you know, may not work. Right? And you need to suddenly go more inferior to get a better puncture.
Correct. Yeah, so, you know, again, Azim, it goes back to the thing I said during the talk is, you know, sometimes we need to look at, you know, old and new procedures, you know, whether they're simple or complex, and always ask ourselves, you know, can we improve on what we're doing? And is there a different way to better understand and also educate people? Because I can tell you that there was a moment where I was trying to wrap my head around, you know, what does posterior really mean, and what does anterior really mean, and what does superior and inferior puncture really mean. And then I told myself, well, okay, this is all relative to a target structure. What is your target structure? Where are you going? And how do those target structures look in the views that we're using to puncture? Because when you do it on echo, when you do it on fluoro, you don't see where your target structure is. We don't see the mitral valve on the bicable echo view.
No.
So we tend to forget where it was located and why we're doing what we're doing.
Yeah, no, absolutely. I mean, that's why now with all my mitral cases, you know, before we try to, especially, I mean, for the MitraClip, not as much, but if we're doing something more complex, like a valve or annuloplasty or something like that, you know, we always, once we're tenting, try and get a 3D again, and get a surgical 3D where you can see the valve, see
Right.
the commissures, and see where your tenting is in relation to that, right? Because sometimes where you think you are is not going to be what's optimal for that procedure and that patient's anatomy.
Correct. Correct.
Yeah, no, that's really important. Um, so here's a question from Luis, one of our fellows. He says, this is a great presentation to understand the views in the cath lab. Is there a web page that we can play the S-curves of the different areas of interest to better understand imaging and fluoroscopy to better prepare for our rotations in the cath lab? I think that understanding the projections is the key to better outcomes. This is like a second year fella. I mean, you know what impact you're having that he's asking a question like this?
Yeah.
Okay, I'm so impressed, Luis. This is a great question. It's
Yeah.
very thoughtful.
Yeah, it's very thoughtful, and Luis, we're what we're trying to do right now, and I'm in contact with a simulation company, is trying to develop an iPad app that brings up all of these S curves and chamber views, and whereby you might be able to somehow manipulate the views and S curves and see structures move and so on. So basically, it would be a simulation application where you can manipulate S curves and maybe drag an S curve and make it more horizontal or more vertical and see what that does to the relationship, or maybe give you a different or different types of patient pathologies that you might encounter with different S curves. And so yeah, it's in the works. We don't have something like that right now, Louise, and it's a long time coming.
Yeah, yeah. I mean, maybe one thing I will share with the fellows is maybe some, you created these great graphs, remember, that you could make posters of.
Right. Yes, I have those posters, Azim. I can send
Yeah,
you some.
yeah. I think maybe you could send those again, and I will share it with everybody because those are good to have, and maybe even print out when you come into the cath lab, and just to kind of quickly remind yourself and have a quick review chart almost
Yeah.
of where the different projections are.
Yeah, Azim, in our cath lab, we have 3 big posters. One is for coronaries, one is for right heart, one is for left heart.
Right.
And it has all of the average views, all the S curves, and what may work for different procedures. So I'll send you those charts, and yeah, you can share them.
That'll be great. That'll be awesome, and we'll share them with the fellas if you don't mind.
Sure.
Okay. Awesome, Nico. Once again, you always blow our minds. I really appreciate it, my friend.
All right.
That was awesome. Thank you so much, and I can't wait to see you in person.
All right, Azim. We'll talk. Let's call me.
Okay, talk to you soon. Okay, ciao, ciao. Ciao.